Endometriosis. This is a diagrammatic representation of the female genital tract. This is the right ovary and this is the left ovary. This is the right fallopian tube and this is the left fallopian tube. This is the myometrium and this is the endometrium. Endometriosis is a disease in which the inner lining of the uterus, known as the endometrium, is found outside the uterus. When menstruation occurs, this endometriotic tissue also bleeds, leading to inflammation. Such inflammation leads to scar tissue formation, causing distortion of the anatomy of the surrounding areas and interfere with their function. Endometriosis is highly prevalent and can be found anywhere in the body. The most common sites are the ovaries, the fallopian tubes, the pelvic sidewall, the uterosacral ligaments, the pouch of Douglas, and the rectovaginal septum. Other less common sites are the caesarean section scars, laparoscopy scars, laparotomy scars, the bladder, rectum, sigmoid colon, intestines, and appendix. In rare cases, endometriosis can invade the vagina, bladder, skin, lung, spine, and even the brain. Until today, there is no accurate explanation as to what causes endometriosis. Many theories have been formed to explain the origin of the disease. One of the most popular and widely believed theories is the Sampson's theory of retrograde menstruation, postulated by Dr. John Sampson in the 1920s. In normal menstruation, blood flows from the endometrial cavity through the cervix out of the vagina. However, according to Sampson's theory, during menstruation each month, a certain amount of menstrual fluid consisting of blood and endometrial tissue is forced backward through the fallopian tube into the abdominal cavity. Usually, the body responds to this kind of spilling by reabsorbing the menstrual fluid back into the circulatory system. However, in some women, possibly due to an immune system dysfunction, the fluid, particularly the endometrial tissue, is not reabsorbed but instead implants itself and grows on the pelvic and abdominal organs as endometriosis. Type of lesions. There are three different types of lesions of endometriosis. The lesions are peritoneal endometriosis, ovarian endometrioma, and rectovaginal endometriosis. Peritoneal endometriosis. Endometriotic lesions are seen on the peritoneal surface. It can be seen as many different lesions. Black or bluish lesions. This is the most common type of lesions recognized at laparoscopy. White lesions. White opacification of the peritoneum that looks like peritoneal scarring or patches. Some lesions will look yellowish brown while others appear as circular peritoneal defects. Non-visible endometriosis. Some endometriotic lesions may not be seen on laparoscopy and only confirmed by biopsy. Ovarian endometrioma. These are cysts seen in the ovaries. Their size may range from a few millimeters to several centimeters. Rectovaginal endometriosis. This type of endometriosis obliterates the pouch of Douglas. Signs and symptoms. The signs and symptoms of endometriosis are pelvic pain, heavy or irregular vaginal bleeding, infertility, painful bowel movements, rectal bleeding during menstruation. Pelvic pain. Most women with endometriosis experience severe pelvic pain, low backache, and cramps before and during menstruation. This is called dysmenorrhea. The pain is typically described as aggravating as the menstruation progresses. For example, the pain on the 4th day of the menses is worse than that on the first day of menses. Some women may also experience intense pain around the time of ovulation. There may be other signs that do not correlate with the menstrual cycle, such as pain during intercourse called dyspareunia and painful urination called dysuria. For dysuria, blood may be occasionally seen in the urine. Heavy or irregular vaginal bleeding. Women with endometriosis may experience excessive menstrual bleeding called menorrhagia or bleeding between periods called menometorrhagia. Infertility. Some women may experience little or no pain at all but are unable to conceive and are usually first diagnosed with endometriosis while seeking treatment for infertility. These are usually cases where the formation of scar tissues called adhesions due to endometriosis has somehow distorted the reproductive organs and hence leads to inability to conceive. Painful bowel movements. Some women may experience bowel pain followed by abdominal bloating, constipation, or diarrhea. The pain may intensify during menstruation. Rectal bleeding during menstruation. Endometriosis involving the bowel may cause rectal bleeding. Diagnosis. Diagnosis of endometriosis can be suspected by medical history, pelvic examination, blood test called CA125, ultrasound, laparoscopy. There are no specific tests to assess whether a woman has endometriosis. Exploring a patient's medical history may give the doctor some clues to the presence of this disease, and it is usually corroborated by a pelvic examination. The pelvic examination may reveal nodularity in the pouch of Douglas, uterine enlargement or irregularity, pelvic masses, or pelvic tenderness. In cases of ovarian endometrioma, also called a chocolate cyst, the ultrasound can detect the ovarian cysts that appear in the form of black bubbles. This is an ultrasound picture showing endometrioma. An endometrioma is seen on an ultrasound as a well-defined darkish area with small whitish areas scattered throughout the cyst. Sometimes, the doctor may order a CA125 test for the patient as it has been suggested that women with endometriosis are likely to have an elevated level of CA125, a cancer antigen, in their blood. In any case, it is possible for endometriosis to be mistaken for other gynecological conditions that have similar symptoms and vice versa. The only reliable way to confirm and verify the suspected diagnosis of endometriosis is through laparoscopy. Treatment. Due to the fact that the exact cause of endometriosis remains unknown, there is currently no absolute cure for this disease. There are, however, several treatment options that aim to relieve the pain of endometriosis and reduce its growth. They are pain medication, surgery, hormone therapy. Pain medication. Some women may experience pain for a short duration. For these patients, painkillers may be sufficient to relieve their symptoms. The types of painkillers administered range from simple analgesics such as paracetamol and aspirin, as well as non-steroidal anti-inflammatory drugs or NSAIDs, for example, Ponstan, Synflax, to narcotic analgesic drugs that are similar to morphine. Surgery. Surgery is the main treatment option for women with endometriosis. Laparoscopic surgery can be performed to diagnose as well as treat endometriosis at the same time. The aim of surgery is to diagnose the endometriosis as well as remove as much of the diseased areas as possible. It is important to do all the necessary investigations to determine the severity of the disease prior to the surgery. The patient should discuss with her gynecologist the extent of surgery that needs to be performed. One must understand that the more extensive the surgery, the greater the risks of complications. Success of the surgery depends on the skill of the surgeon. An experienced laparoscopic surgeon will be able to excise all the endometriotic lesions in a single surgery. On rare occasions, a laparotomy may be necessary to excise extensive endometriosis. Hormone therapy. Endometriosis is known to be exacerbated by the hormone estrogen. Estrogen is produced by the growing oocytes in the ovaries. Whenever there is menstruation, the endometriotic lesion will also bleed, causing pain and formation of adhesions. Therefore, one way to suppress endometriosis growth and relieve its symptoms is to lower the estrogen levels by preventing menstruation. Hormonal therapies are usually given after laparoscopic surgery. Some of the therapies available are gonadotropin-releasing hormone analog, or known as Gnrh analog, combined oral contraceptive pills, Progestogens, danazol, dimetros, Mirena, aromatase inhibitor. Gonadotropin-releasing hormone analog, Gnrh analog. Ovulation is controlled by two hormones produced by the pituitary gland. The pituitary gland is located in the brain. Above the pituitary gland is the hypothalamus. The hypothalamus produces a hormone called the gonadotropin-releasing hormone, which stimulates the pituitary gland to produce FSH and LH. The FSH and LH stimulate the oocytes or eggs in the ovaries to grow, and the developing oocytes will produce estrogen. Gonadotropin-releasing hormone analog, Gnrh analog, will block the stimulation of the pituitary gland by the gonadotropin-releasing hormone. This will cause the pituitary gland to stop producing any FSH and LH, thus preventing the growth of the oocytes in the ovaries. As no oocytes are growing, estrogen production will cease. The patient will stop menstruating. She will be in a menopausal state called pseudomenopause. Gnrh analogs are given in either monthly or 3-monthly injections. The side effects of Gnrh analogs are menopausal symptoms such as hot flushes, sweating, dry vagina, mood swings, osteoporosis. Thinning of the bones called osteoporosis can occur, especially if the injections are given for a duration exceeding 9 months. These injections are also expensive. Advantages of Gnrh analogs. Gnrh analog is an effective treatment in all women. Menstruation will cease. Since it is a monthly or 3-monthly injection, there is also no need to remember to take tablets every day. Oral contraceptive pills. Oral contraceptive pills, or OCP, contain low-dose estrogen and progesterone. It works by preventing ovulation and so prevents the ovaries from producing estrogen. Each pack of oral contraceptive pills contain 21 tablets of active pills. Oral contraceptive pills are usually taken for 3 weeks, with a 1-week break to induce menstruation. However, 3 packs can be taken continuously for 9 weeks, and then a break is taken for 1 week. In this way, the number of menstruation in a year can be reduced from 12 to 4. Oral contraceptive pills may be prescribed immediately after a laparoscopic surgery or after Gnrh analog treatment. Since oral contraceptive pills are cheap with minimal side effects, it can be taken for many years until the patient is ready to conceive. The advantages of OCPs are they are cheap, with less side effects, and can be taken for a long duration. The disadvantages of OCPs are a tablet have to be taken every day. It may cause irregular bleeding called breakthrough bleeding while taking the tablet continuously. Progestogens. Progestogens are synthetic progesterone. They are given to prevent ovulation. Progestogens are usually given continuously. There are many types of progestogens available in the market. An injectable progestogen available in the market is Depo-Provera. This is a 3-monthly injection that prevents ovulation. The advantage of Depo-Provera is that it is a 3-monthly injection and patient need not remember taking tablets. The disadvantage is that it causes intermittent bleeding. It may not be suitable for women intending to conceive in the future because it takes a long time for a woman to start ovulating after cessation of the injection. It can also lead to osteoporosis. The newest oral progestogen in the market is Dynogest, called Visan. One of the side effects of oral progestogens such as Dynogest is that it can cause irregular pervaginal bleeding. Due to the absence of estrogen, continuous progesterone therapy may lead to osteoporosis. It is usually recommended for 6 to 9 months. Danazol and gastrinone suppresses the endometriosis by making estrogen levels lower and androgens, mainly testosterone levels, higher. They were commonly used in the 1980s but rarely used now. Danazol is usually given in high doses of 600 to 800 mg a day for 6 to 12 months. Gastrinone is given at doses of 2.5 to 5 mg twice a week for the same duration. Side effects due to high androgen levels: weight gain, bigger muscles, oily skin, increased body hair, hoarseness of voice, cramps. Side effects due to low estrogen levels: low libido, hot flushes, smaller breasts. Mirena is an intrauterine contraceptive device or IUCD that contains a progesterone called levonorgestrel. The uterus will absorb the progesterone, leading to a decrease in menstrual blood flow. When there is less menstrual blood flow, bleeding from the endometriosis will also decrease, thus suppressing endometriosis growth. It can be left in the uterus for 5 years. The advantage of Mirena is that the patient need not take daily medication. The amount of progesterone required to suppress menstruation is also very low because it is directly absorbed into the uterus. As only a small amount of progesterone reach the rest of the body, side effects of progesterone is minimal. The disadvantage of Mirena is that it may cause annoying, irregular, and prolonged spotting in some women. It is also not suitable for women who have not had sexual intercourse. Aromatase inhibitors such as anastrozole and letrozole are drugs which inhibits the hormone aromatase. Aromatase is a hormone that converts testosterone to estrogen. This will lead to a decrease in estrogen production, especially in the endometriotic lesions. The side effect of this medication is that it may lead to osteoporosis or bone thinning, tiredness, and menopausal symptoms. The choice of treatment depends on the patient's age and individual needs, such as the desire to conceive and the severity of the symptoms. Some doctors prescribe hormonal treatment just based on the suspicion of endometriosis by history, examination, and ultrasound. This is not recommended because most of the treatment has side effects, and it is better to perform a laparoscopic surgery to confirm the disease before commencing medical treatment. Endometriosis can recur after surgery and medical treatment. The chances of recurrence is higher if the surgery is performed by an inexperienced surgeon and if most of the endometriotic lesions are not excised. If the patient is not contemplating pregnancy immediately after the surgery, continuing medical therapy is essential to suppress any endometriotic lesions that has not been excised. The cheapest treatment is the oral contraceptive pills. Endometriosis is a common gynecological problem. It usually presents with pelvic pain, especially pain during menses and during sexual intercourse, and also infertility. It can be suspected by taking a good medical history, performing a pelvic examination, and a pelvic ultrasound scan. Laparoscopy is the gold standard for the diagnosis and treatment of endometriosis. Laparoscopic surgery for endometriosis can be difficult because endometriosis frequently involves vital structures such as bowel, bladder, and ureter. It is important for laparoscopic surgery to be performed by an experienced laparoscopic surgeon. There are many medical treatments that can be prescribed after laparoscopic surgery to prevent recurrence of the disease.